You will be one of the best residents. You will be a star. You will not see sun for 11 months. This is a secret. And they didn't get, place to shower. For the example of that.
Hello, Dr. Khillan. It's very nice to meet you.
Hi, Iuliia. Thank you. Second time for doing this for all these students. Your first video was very famous and I got a lot of compliments. So it was very helpful to the students. So let's see if we can help them again and maybe a little bit this time in starting their residency.
Yeah, first of all, I would like to introduce you again. So today we're having an interview with Dr. Khillan, who is an assistant professor of medicine in State University of New York. He has great experience in teaching medical students from the US and from all over the world. He's also a medical oncologist and he runs a medical center, which is called Brooklyn Cancer Center. Thank you again, Dr. Khillan, for agreeing to participate in this interview. And yes, interview season is coming to an end. And there are plenty of things to discuss. First of all, we would like to talk about the ranking list and how to choose residency properly, what things are important in this process. And then we will move to discussing the ways how to adapt to new healthcare system, which are the most hard things in your life when you're an intern and stuff like that. I believe that this video could be helpful for everyone who is on this edge to beginning new life. And the first question is how to rank programs and what are the most important features to pay attention to during this process?
Yeah, so that's a very important question. Everyone is very nervous about the rank. So just to be clear, so the way match system works, it works in the favor of the resident. It does not work in the favor of the programs. It works in the favor of resident. What that means is when you guys want to match a program, right? So you see that you have interviewed in like 4 places and you want to go to program A, but your interview was very good at program B, and you think that your chance is more in B, even then you rank program A first. It's okay. Because if you don't get in A, B is there, the second is there. They will give you option to rank, all your programs. So it doesn't matter even if your first program A interview is a little bit weak, but you like the program. So if you like the program A, you will match that program number 1. If you don't get that, you automatically, go to the second and third and fourth. So you rank your programs according to what you like. But if you think that there is a program which you like, but your interviews was really bad, like you have no hope, so that program I will not match number 1. That program I will match number 2 and number 3. But if your interview is like 90% and 95%, then I will go where I want to go. All right. So when you make your rank order list, first of all, you have to decide what you're going to do in life, right? This is a very, very important decision. Are you going to be a hospitalist or are you going to be a specialist? So if you're going to be a specialist, you're going to rank university programs or programs which have fellowships, right? And if you want to do a hospitalist, then you're going to rank those programs where they don't have fellowships. Because this is what I have seen. Programs where the fellowships are, they like to take, residents who want to be a fellow, right? But community programs, if you tell them that you want to do fellowship, so sometimes even if your score is good, they will feel that, you will be like unhappy in that program. So they don't want to take those residents who will be unhappy because they want to do fellowship and they're not getting it and they're very frustrated, So that's the main criteria. First of all, you have to make sure the program you rank, they like you, your interview went very well, and you like them. And the second criteria is if you want to do a fellowship, you rank university program on the top and community program on the bottom. But if you want to do hospitalist, then sure, you want to rank, those programs on the top. But there are some hospitals like Cleveland Clinic, right? They have the best hospitalist program. So if you want to be a hospitalist and your scores are amazing and you want to do in Cleveland Clinic, so I will match Cleveland Clinic number 1, right? So that's no brainer. So match works in favor of the resident. So you can rank your programs as you like, and if you don't get it, they will keep going down the list. One more thing I want to tell all the students, all the applicants actually. So when the programs match, right? So they don't match if they have 10 positions, they don't match 10 residents or 10 applicants. If they have 10 positions, they match around 50 applicants. So just to give you an example, if there's a program who has 20 spots and they interview 300 people, they're gonna match around 150. So your chance of getting into that match list is very, very high, 50%. 50% is amazing. And then some of the program, not some of the program, most of the program, they're gonna match repeatedly same applicants, right? There are top 1,000 applicants who are amazing scores. They are amazing, they are nice, so everyone want to get them. But how many programs you can go to? One, right? Everybody gonna go to one program. So there will be a lot of repetition. So when they match, so they match 150 resident, and we have seen even the last applicant they match actually get the spot, especially little weak programs, because the top ones, they're gonna go to these nice programs. So never think that, oh my God, I got very few interviews and my program has only 20 spots. Will they match me? Of course they will match. They have to match 50% of their residents. Everyone try to interview around 5 to 6 times, right? So if they have 20 spots, they, around 200 to 300 interviews. This time actually, I think interviews number was less too because of all this coronavirus and, online interviews. So spots were not that many. So I think this time, if you have an interview, your chances of match is very high in that program. Even with the few interviews, people who are having 4 to 5 interviews, their chance is great if they have the interview.
So the programs should think about ranking more than applicants. For applicants, it's just important to rank programs according to our preference, and programs take into consideration applicants' perspective on this. So, for example, this applicant is too great for our program, so we should not rank him too high because he's probably going to another program, right? So this system
exactly.
benefit.
Sometimes they will not match. Sometimes they will not match if resident, if somebody is very good scores, publications, clinical experience, and very good in interview, they're like, oh my, this is too good for our program. So they don't match that. No, that is real. I mean, some of the programs where they know that this applicant not gonna come to us, they don't want to waste their spots. These program directors, they are very smart. I said it last time also. This is what they do for a living. They know it very, very well.
Right. Great. Thank you for answering. And I have a second question. So once we are matched, I hope everyone watching this video will match this season. From your perspective, how to adapt to internship? What advice would you give? Should they learn something before their internship, or they should just relax and try to take this time and spend it with their family?
Yeah, excellent question. So this is what I will do. On March, I think it's 15th or 17th, when match comes, right?
19 this year.
19, yeah, whatever date. So if you get your result that you matched on March 17th, I will go on travel. I know it's Corona, but I will go if I can. I will go on travel for 2 months. I will do whatever I want to do. I will enjoy my life for those 2 months. All right. And then around May 15th, I will land in United States, May 15th. Okay. That is around 1 month before you start your residency. I don't want all the people who are listening to this video land in US 1 day before their orientation. They will be so confused. They will be so disoriented. They will not have place to stay. They don't know how things work here. They will be, that first impression when you go in for that orientation is your last impression. Everybody just think about you based on that first day. I will come here close to the place where you got the residency. I will find a place to stay. Very important, you may have to buy a car. There will be so many difficulties I have seen to the resident who just coming here like, oh, I'm just coming from Sri Lanka, and today is my orientation. I couldn't get a hotel. I couldn't get any room to stay, and they didn't get place to shower. Things like that. Don't do that. Just come here 1 month before, find a place, start living there. This will be your 1 month investment. But this 1 month investment, you will be one of the best residents for that program for next 3 years. And when you go prepared there, when you go for an orientation, read all the documents they're sending you. Every document they send you has a meaning. They don't send you anything for fun. They're going to send you so many things, so many courses you have to do. Do that. And whenever you're doing it, even you're doing a HIPAA course for your hospital, you're doing their other courses, just pay attention to it, because that will become your habit. And it's not that anybody's judging you on that or looking at you, but that's the general impression they will get, that, oh, this is the resident who does everything properly. So you will be one of the best residents over there. All right. So that's my advice. Come here a month before, start to live there. You know the area, you know where the hospital is. You may have to buy a car. Like there are some parts of the United States where you cannot survive without a car. Or at least when you are here for a month, you will know that if you cannot buy a car, or you don't have money to buy a car, you live very close to that place, right? So that there is, some way you can reach for your job. So these are very, very important things before you start internship. Now, the second issue is now what to study for internship. What is internship, right? So there is not, some people did write few books about, how to survive internship and all that. And they're good reads if you want to go over them, internship survival guide or something like that. So if you can buy that book, read that, that's fine. But there are few things which you need when you go for an internship. You need to read what are the common admissions in any hospital, in any geographical area, like pneumonias, CHF, MI. There are 4 or 5 or 10 diagnoses which are going to keep coming again and again and again. And I want you guys to read about that, because that's what you need to know: how to treat community-acquired pneumonia, how to treat hospital-acquired pneumonia. You have to see, is your hospital is attached to a nursing home? Like one of the hospital here, which I used to go, is attached to a bariatric nursing home. So a lot of big people, they come from that nursing home to that hospital. So most of the times you get patient with pulmonary embolism, patient with diabetes, diabetic foot, DKA. So you should know all those things, how to treat that. And if you do know that as an intern, you will be a star, right? It's not that the other guy doesn't know or know less than you, but he did not put attention to read those 10, 15 cases. And that will make the whole difference. The whole internship, whole residency, you will be star by just knowing these few things. That's my own experience, I'm telling you. So read about those local diagnoses, of the hospital. Every hospital has local diagnosis. Try to see if you can, meet one of the senior residents or chief residents. Chief resident, they are sometimes too arrogant, but, like second years or third years, if you can make, friends with them. So start living there, start visiting, and, because anyways, you're going to go there, make an ID, make this, make that, this course, that course. So when you go, just start, making friends in the hospital. So this is what I will do in internship. During internship, so when you are looking at a case or something, very busy. The reason I told you guys to go for vacation is because this internship, this is what's going to happen. And wherever you go, you guys are going to go in a hospital before sunrise, and you guys will go home when sun sets. You will not see sun for 11 months. Only 1 month of vacation, you will see that. So the internship is so busy everywhere, but the busier the internship, the better doctor you will become. If a program internship is not busy, so you will become an average doctor. Like in New York, we have seen, we were so busy, they killed us. But now we are gold. If we apply for a job, people prefer us on other other residents who are done their residency from, say, Arizona or Wisconsin, because they know that we have gone through this rigorous training and we can do anything. If you can survive in New York, you can survive anywhere. So, so that's the difference.
Sorry, you did your residency in New York, right?
Yeah.
How was your experience?
It was really hard. We did not have any help. There was negligible nursing help or a lot of scut work, I will say, we used to do. So my routine was, I did my residency in Kings County Hospital, and I'm not complaining about it, but I'm telling you the truth, what happened. So in the morning, we used to go there between 6 and 7. We draw blood on every patient in the morning because nobody will do it. I heard that now things are different. Now they have phlebotomies. Now it's less, but when we were there, and then we look at those patients and everything which you need to do on those patients, CT scan, MRI, this and that, is basically on you. You put order, nothing will happen. You have to go down, talk to the attending, approve the scan, and then beg the technician to give you time to bring patient down. And sometimes we did wheel patient down ourselves. So that's what we did. And you do that till like 10, 11 o'clock at night. Then you go home, you're dead, you go to sleep, and you come back again at 6 o'clock. And this keep going. Yeah, for 11 months.
What helped you to survive? Like, what inspired you to go on, to wake up in the morning?
I didn't have any choice. What choice I had? There's no choice. Right? You have to do it. So I think when I was driving back, I think music saved me. I like music, and I put music in my car and I listen to it. And when I reach home, it recharges, and I think we didn't have choice. There were some months like clinic months. So they give us like inpatient floors, then there's clinic month. Clinic months were a little better. So in internship, I think I got maybe out of 12, 7 really, really hard months, 2 months maybe moderate, and maybe 2 months were light, and 1 month vacation. That's saved.
Now I am.
Yeah.
Why currently a lot of attention is paid to this resident wellness, all those projects, because previously it used to be.
We didn't have any of that. We did not have any of that.
Yeah, but the depression rate was high and burnout and stuff like that.
Yeah.
Dr. Khillan, as a little follow-up to the question about internship, is there any way to prepare for the system for those, technical things such as EMR and all the logistics of the healthcare system? Like, what advice would you give?
Yeah. So some programs, not all, some programs will let you shadow like week or two before. Like if you are starting your residency on June like 20th, right? And your orientation, everything start on June 1st. So if you request them, they may let you shadow with some teams, like real shadowing, where you go in, you wear white coat and you round with the team and you see the patients, and you don't write notes or anything, but you learn. And when you do that, if resident is nice on that team, they can teach you a lot about the EMRs, because every hospital has different EMR. Basically, they are same. I mean, what you say, the function is same. They're made for writing notes, looking at the labs, but their functionality is different. And you will only learn when you use it. You cannot read about it. There is no reading. You can read whatever you want about this EMR, but you will learn it when you use it. Like, okay, now you're going to write a note. Okay. Then when you write a note, then you will know, oh, there are like 100 types of notes. Then there are consultations. There are 100 types of consultations. How to put an order, how to put a CT order, how to put a sono ultrasound order, what words to type. And day by day, you will keep learning. And within 3 to 4 months, I think you guys will be, masters of that EMR. But if you can do that, like, as I said, start living next to the place where you get this around, I will say month before you start. Yeah.
Okay, next question is related to fellowship. So we just briefly touched this topic. When should one start doing some research project in order to be involved in the fellowship program? And what advice would you give for those who are eager to pursue the specialist career?
All right. So there's a little change in fellowship. In last, I think 5 years ago, they changed the rule. Before you apply for your fellowship in second year, when I was doing my residency. So I applied in second year, I got it, and it was all set. But then they said it's too early. Maybe you're too young you're still intern and you don't know what you want to do and you have to decide in second year. So now you do that in third year. So now you guys have a little bit more time to think about fellowship. But there are some residents, some students, some applicants I know who are they know they want to do fellowship and they even know what fellowship they want to do, which is good. If you have your goal, you can do well. Like if you know that you want to do a cardiology fellowship from day one when you enter, right? So you start mingling with cardiology people on day one or even before, you know, just start talking to them. Try to find out who's the chief of cardiology. How can you do some electives with him? Or even how can you do some rotations with him? So when you do internship, every month, you guys will have a dedicated attending with you. And then people who want to do cardiology, they should do their rotations with the cardiologist, or they should do most of their rotations with the cardiologist. That can be manipulated if you are good with the chief resident. Okay, so this is a secret. So if you want to do GI, you do your rotations with the gastroenterologist mostly. If you want to do endocrine, you do most of your rotations with the endocrine. And it's always beneficial to do a rotation with the PD when he's on this floor. But that's very difficult because program director is on the floor like maybe 1 month or twice a year. So chief resident tend to give them the best residents. So if you are the best, you will get it. Otherwise, you will not get it. So this is how you will, you will become a little bit more closer to those people who, these are the ones who are going to give you a fellowship. Your chances of getting fellowship is maximum in your own program. And now, when you start doing research, from day one, if you see a case, and if you want to write it up, write down. Even small things matters, for fellowship. Like if you want to do gastroenterology or you want to do oncology. So if you see some cancer patient you think is very interesting, just show your interest. Talk to the chief resident. I want to write up this case. I want to do this. Because, when you're doing residency, it's very difficult to do bench work unless you are in like a really big university program and then they have a basic science labs and stuff, which most of the hospital, they don't. So what you need to do is for fellowship, you have to do clinical research, and which is okay. I mean, everyone knows about it, and they know that, um, uh, we don't want you to be PhD in like blood or something to be a hematologist. No, we don't. We just want to see that from day one, you are interested in hematology oncology. You are rotating with people who are doing hemo. You are doing some electives in hematology oncology. Most of the program, they offer electives in second year, and some do offer like 1 month in first year, like downstate they offer in first year. So when they offer you elective, you do that elective of that fellowship which you want to do. And if you change your mind next year, then you do the one which you want to do in second year, and that's okay. But I have seen people who are very, very determined from day one. Like they're like, I'm going to do cardiology, nothing else. They get cardiology, I have seen.
Dr. Khillan, I have a question related to what you said. So, for example, if one starts doing, for example, research in endocrinology in the first year, and then he changed his mind in the second year and started doing research in cardiology, and then he applies to cardiology, will his previous research on different topics do him some favor? Or only research on the specialty counts?
No, everything counts.
Oh.
Even if he has done something in endocrinology and he wants to do cardiology now, every medical field is interconnected, right? Endocrine is also sort of related to cardiology too. So again, it's the effort which everybody looks at. Everybody looks at that. What are you doing? Are you trying? And it's okay. You can you be honest. Just say that first I wanted to do endocrine, but I worked with endocrine. I didn't like it that much, and now I want to do cardiology. So that's why this paper is in cardiology. That's okay.
So you basically just write everything you did in your CV, and then they just look it through, and yeah.
Yes, yeah, they just look it through. Everybody want to see that you have few papers and you have some work you have done in any field, because you're doing right now internal medicine residency, right? You're not doing cardiology. So it's not that you're only seeing cardiology patients. What if you see a very interesting cancer patient and you want to write it up, though you want to do cardiology, it's okay.
Great, thank you very much. I have a personal question for you. Again, what was the hardest thing for you during your residency? How did you establish maybe work-life balance even in those conditions that you had?
Right. So the toughest part, I think, for me was when I went there. The whole cultural change, right? It was very very different. I did residency back home in India. I did residency, and it was surgery, and here I'm doing medicine. So for me, it was a little different. The thought process were different, and a lot of my actually medical attendings told me that you think like a surgeon. They're like, you think like a surgeon, and here you should think like a medicine doctor. Sometime I was like too aggressive in doing few things, like because I was surgeon, so I was very good in putting lines and stuff, and I used to put lines without any, like I still remember I was in the ED once, and there was this ED resident trying to do an LP, and it was like his like half an hour, and he couldn't get it. And I'm like, what are you doing? Let me actually tell you how to do an LP. And so 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 he's like, oh wow, how you did that? I'm like, I've been inside, I've seen this, and these are principles. And but on the medical and um, it was very fast. People were really too quick for the things, like how to say that, like people are very quick to make connections with big shots, and I didn't know that will be important. I didn't make any connection. I did whatever I thought uh, that will help my CV by doing work without making any connection. uh, did it harm me? I don't think so. I think later on they did. So they become successful in getting fellowships, like better fellowship. I don't know, I wanted to hemonc, and I think at that point cardiology and GI was the like hot spot. So some of them did get those because of all these, I don't know what you call that, I don't want to use that word, but so they like by making connections, I will say.
Social
So
networking, let's call it that.
yeah. Yeah, but I didn't do it, and I did with work. Like really, I actually did bench research also, because downstairs we have a lab. I worked with a PhD for a few months. I did some work on platelets and a lot of papers. I won a lot of awards. So I got my fellowship, and afterwards, now I'm looking at my clinical success in the like in my practice. I'm very very successful than other people. So maybe that was my reward now. I didn't get it then, but I got it now. I think that was little. I think I was a little slow in making connections. That's why I'm telling you guys, like if somebody wants to do cardiology, just start. These people, like I went there and I didn't know these things, that you have to do rotations with this, and this. I didn't know that. Wherever they put me, I go and do it. But people knew where they're going to do rotation, and this guy wants to do cardiology, so he will do all his rotation with cardiology. All these things were so, pre-planned. And when I went in, I have no idea that, these people are preparing all these things. They're checking their email, and I didn't pay too much attention to those emails and stuff. I was like, like you have to work, right? That's what I thought. But it was more than work. That's why it's important to check all those emails. Go there a month before, participate in everything, try to fight for everything, because otherwise other people will take it.
Dr. Khillan, that's very interesting. I didn't know you were a surgeon back home. Could you please tell us, why did you come up with this idea to move to the US, and why didn't you try to pursue surgery career in the US?
Yeah. I was not like a surgeon. I was a surgical resident. 2.5 years I did surgery. So when I came to US, the reason I didn't do surgery, it was I got very scared from pyramid system. So in surgery, I don't know if you know or not, in surgery, every program, they have around 30 to 35 spots in surgery in first year. Then from that, second year, they take 25. So the 10 resident, they leave and you go 25. And then third year, out of those 25, only 7 or 8 go further. So for me, I was on a visa. The chances of me completing those 5 years were very, very difficult. And I didn't want to live in that limbo. So I'm like, no, this is too much. And the reason I did oncology, my surgical residency was done in a cancer hospital in India. So I did a lot of work on cancer. And in India, when we see a patient, mostly surgeons, they give also chemotherapy. So we were giving chemotherapy to not very extensive chemotherapies, but basic chemotherapy. So I knew about chemotherapy. I knew about cancer. So then when I came here, so I have two options. One, go in surgery and be unsure of my future for 5 years until I get it. And then everybody was saying that your chances of getting prelim surgery is easy. You will get it, no problem. But your chances of getting categorical surgery is very, very difficult. So I'm like, no, I don't want it. So I changed my mind. I did medicine and then I picked hemonc because of that background in surgery and surgical oncology.
Well, actually, a lot of people from all over the world, IMGs, I mean, they change specialties because of these low chances of like being enrolled into high competitive residency programs such as dermatology, surgery, whatever. How did you prepare for your new environment? Because even physical exam differs among specialties. So did you practice this, or how did you prepare for your residency?
That was the hard part. I told you, my physicians, my attendings always tell me, like, you work like a surgeon. Because I was a little more quicker than other people, because I just see that if this person is dying or not, and then act on it, which I save a lot of lives. But sometimes in medicine you have to be thorough. So it took me some time, I think 6 to 7 months to make myself change the way I look at the patient, not as a surgeon's eye. Then I have to, I think after my second year, I was much better. But when I was fellow, I was very good. I mean, I've totally changed. So it took me 3 years to, to change that mindset from a surgeon to a physician.
But how would you characterize the expectations like program director and faculty had when you was enrolled? Like, how did they perceive your mistakes, for example, or those difficulties you had?
Actually, it was the other way. They liked it. They liked, like, my senior resident, they liked it. I was putting lines for them. I was doing chest tubes for them. So I was doing, like, a lot of those things. But it was just when it come, like, presentation wise, right? When you present a patient. So some of them do such a detailed thing. And I'm like, why are you doing that? like I think that you don't need all that, but then slowly it helped, actually. So no, they we were 3 people, actually 3 or 4 in my batch who were surgeons before, and we were very popular. Some of these kids, they didn't know how to put an IV line, right? They come in and they're like, oh no, can you put a line? And oh, can you take blood? Like, I can take blood from anywhere. Like, I go in femoral and get blood. Like, they're like, oh, how can you do that? I'm like, there's a femoral vein in everybody, so you can do that. like then I remember my first code. So it was me and my second year was running the code. So he was very busy, and we have to put a line. We are waiting for surgery, and I asked him, I said, I can put this femoral line for you, no problem. He said, oh, you can? I said, yeah, I can. It's okay. He said, okay, you put femoral line. So I put femoral line, and he's like, oh, thank you.
That sounds amazing. I'm 100% sure you were perfect, but I think you also had mistakes. And how do you feel they perceive those mistakes? Because a lot of people are concerned, like how high expectations are and how should you react to your mistakes, because we are just starting residency and we don't know a lot of things. So
If you keep making same mistake again and again and again, they don't like it. They want you to learn from your mistake. So if you did a mistake, it's okay for first, one time, two times. But if you keep repeating your mistakes, then you're in trouble. Then they write you up. So because our mistakes can take somebody's life. So it's very, they take it very seriously. So one thing I want to advise everybody: if you don't know, you ask. It's okay. It's okay to ask. You will not, nobody will look down upon you if you ask. Everybody likes it when you don't know, you ask, even if it's a simple thing. And that principle even I use still with my students here. I tell them, you're not doing anything if you don't know. You ask me. No question is dumb question. Ask, it's okay. Or look up. Every hospital you go to, you guys will have every access to up to date, to PubMed, to Medscape. All these libraries are just on the computer. If you see a patient, you check. It's okay. Try not to do mistakes. If mistake happens, admit it and don't do it again. That's it.
Great. Thank you very much. It's very important advice. And I have a question regarding residency programs. Would you please a little bit elaborate on your opinion, like how residency in big cities such as New York or Chicago differs from those which are located in little cities?
Some residency out of New York, out of Chicago, they are much better as for the resident, for an intern. So nurses, they take all the orders. You just put an order and then, your job is done. Not in New York, not in New York and Chicago. Here, you are the one who is responsible for everything. There are still some hospitals in New York where nothing will be done if you don't do it. So that's the difference. But again, it's not negative. They prepare you very well, so you will be a very good doctor, because when you go in real practice and then that you are the person who's responsible for that patient's care. So your whole attitude towards your work is different than people who are trained, like as I said before, maybe in somewhere in Midwest, Wisconsin or Arizona or New Mexico. Over there, I see resident comes in. That's why sometime in New York, we don't like to take those residents from other states for fellowships, because when they come in, they cannot adjust to the system where they have to do something. They are used to just giving orders. They just give orders and that's it. Things get done. Not here in New York. Here things will not get done if you don't check it. It's not like you put orders, you go home and you expect next day things will be done. Not in New York, but things will be done in maybe in Arizona. Things will be done in Wisconsin. So that is the difference between doing residency in New York. So in New York, residency is resident dependent. Other places, those residencies, they are nurses dependent. Most of the hospitals are run by nurses, and nursing is very good. I mean, it's so good that sometimes you will see that patients, they don't even, some of the hospitals, they run by nurses. Doctors comes just for consultations or seeing the patient, and they run it very well. It's not that they do any bad job. So that is the difference. Our hospitals in New York, Chicago, residents are the one who are running the show actually.
Thank you very much. And I have the last question. We briefly touched this topic. This question is related to the ranking list. So you mentioned that it is important to choose residency according to your preferences for the future careers. For example, if you want to pursue fellowship career, you should either choose a residency with fellowship or with a great fellowship match rate. But what are other features we should look for in residency programs? Like a lot of people, they speak about this gut feeling, like when you feel that the team fits you well or you fit this team. Some of the people pay attention to the location. What advice would you give apart from your future career choice?
Yeah, so very, very important, when you go for an interview in a program, right? So if you have a choice, like some people will not have choice. Some people have 3-4 interviews and all of them are in New York so all programs are same. So it's not much difference. But if you have a choice, if somebody who has 10, 15 interviews and you have a choice, then I will definitely go. There are a lot of forums where they discuss all these things, like which program there is more scut work, which program there is, So I don't want to do scut work, right? Unnecessarily. Yeah, it made us good doctors and all that. We can draw blood better. But if I have to do it again, uh, it was not my job to do a lot of things which I did at that point, right? So if I have a choice now, I will go to a program where, okay, fine, if nurses are having difficulty obtaining blood from someone, I will go do it. Out of 10 patients, 1 or 2 patients, if I have to do it, I go do it. I will not complain about that. But what happened to us is we were like, basically they used us. Nurses used us to because they knew that we're going to do it. So they don't even try. So I will look into these kind of things, that and there are resources to see that, what is the hospital infrastructure, how many phlebotomists are there, is there a phlebotomy team, is there an IV line team, right? Because sometimes you are doing something, and you're taking care of a sick patient, and there's another patient who need an IV line. Now you have to stop, taking care of the sick patient, and you come here putting an IV line when it's such a simple thing. Most of the hospital have IV teams. So you just page IV team will come and put an IV line, right? So if I have a choice, I will go to a program who have more infrastructure. Absolutely. Like more than, if they're fellowship or not, or, if we are comparing two programs where both of those programs have fellowships, and one program, they give you more support, I will go to the program which give more support. Absolutely. Why I want to kill myself?
Yeah. Thank you very much, Dr. Khillan. And actually, our previous interview was very popular, and I received a lot of great things people said about this. And they also asked me about Brooklyn USCE and how to organize a clinical lecture there. Could you please tell us a little bit about the company, why it was organized, how it differs from other companies which organize clinical electives, and tell us maybe how to apply for the elective.
Okay. So the reason we made that company was when, like 5 or 6 years ago, when students start to come here, somebody asked me, can you have some students rotate with you? I'm like, okay, how, why? They said, oh, now students, they require clinical experience, and, we're looking for physicians. And my clinic is busy, like very busy. It was from day one, we were very busy. And they said, you have a lot of patients, they can help you. So that's how I started taking students, not from Brooklyn USCE, was not born. And then when I was talking to the students, I was asking them, so they were coming from all over the world. And, and I met some of the most amazing people. You are one of them also. I have seen these, these amazing, smart people. I'm like, wow. Some of these students comes in, and, the amount of knowledge that fascinate me. So I was very interested in pursuing it more. And then I start talking to them about the finances, how they come in. And it turned out that they were spending like hell of money, to do these rotations and all that. And then I was talking to some of my physicians, in my group. I'm like, we should help these students. Like, they are like us, right? I look myself into you, into other students. Like 20 years ago when I came here, it was exactly, I didn't have any money, and I know how difficult it was, to spend that money in dollars, right? So I was like, no, we need to do something to reduce the cost of it. So I spoke to all my attendings. It turned out the companies were giving us very little money and keeping big chunk of money as commission. So I'm like, okay, guys, let's do this. So if company give us this amount A, maybe $10, let's do 8, and let's give these students rebate on that, like big rebate. So we actually, we decreased the cost all over the board after that. When we made Brooklyn USCE, we made it so cheap than other companies, like half the price. Now, because we have half the price, the reason we were able to do was there was no middleman, right? It was just directly us physicians. So people come to us directly, and we charge them very nominal. And all my doctors, I have to thank them too. They said they were also agreeable to, getting less money, just because they're like, yeah, all of us, we came through the same route, and we can imagine how difficult is it to pay this much money when they come in. So right now, I think our three rotations, 3-month rotation, is in some companies they will charge you the same amount of money for 1-month rotation. So it's that different. The price wise is very, 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 very different. And its rotation is the same. Those companies also send students to us. So we are the people who are doing exactly the same thing, exactly the same rotation with half the price. So that was the main purpose. And then when I was doing it, then I saw some of these students, they were very interested in doing research, doing other things. And then I have get some of these guys, they are so, like, I have seen talent, like they are so good with media, they were so good with publication. I have a girl who actually a resident in downstate. She's so good in publishing papers. You give her a paper, she will read it and she will fix it and she will write it. I got a guy, a Chinese, I forget his name, a kid from China. He wrote a paper for me for New England Journal of Medicine in the same format. As if you read that paper, I will send you, it will look like you're reading it from New England Journal of Medicine. So I met so much talent, and then I'm like, you know what? I need to expand it more. So we expanded it into research. We expanded it into more, not only the clinical research. A lot of students who really liked it, actually, they come for a month, then they stay with me for like 6 to 9 months. And I feel proud of that. Every year I have like 3 or 4 students who stay back out of like 40, 50 who do rotations with me. They stay back with me and they do like, they're in my clinic from 9 to 9 and they're so happy doing that. I have never seen them tired or anything. Like they do this work, like they love it. So this is how we started, and we are growing tremendously. Now we are having more rotations in, I think we're doing in New Jersey, we are doing one in Denver, Colorado. New York, we have some more. I think there were some students looking for pediatrics and family practice, so we have all that now. So yeah, so that was the reason, just to help students to lower their burden, this financial burden from them.
So as far as I understood, students can apply for research elective as well.
So we have this collaboration with a team, a research team, because I'm very busy in clinical stuff, so I don't have time for research that much. But we have a collaboration with another company which does research, and yes, they can book research elective also. I think it's for a month or 2 months. If you go to website brooklynusce.com, we have all the links there. So yes, so we have research electives, we have clinical electives. What we want to do is we want to make sure when you guys apply for residency, you guys have your whole application it looked nice, right? It should look nice with the clinical experience, few papers, and maybe CV also should look very, very good. Because sometimes I have seen some CVs, because English is our second language. The way we write, it's a little different than Americans. They write their CVs and that. And there's another component of our companies now. We have someone who can actually professionally help people how to write their CVs and personal statements and letter, all those things, because all these things matter. When you send your application, everything should be perfect. I have seen sometimes people say, oh, it doesn't matter, that it's personal statement. Everything matters. We spoke about that, starting from your hairstyle to your score, everything matters.
Yeah, Dr. Khillan, and I have a question. Actually, I underwent telerotation in Brooklyn USCE, and I was very excited about that. And just the information for applicants, telerotations are perceived in the same way as actual rotations. When all those visas restrictions and travel restrictions cancel, will you like proceed with organizing those telerotations, or the amount of those will be reduced? Like, what is your opinion regarding this?
So telerotations, right? You
Yeah.
have seen by just doing telerotation, you got interviews, right? So it worked, right? So
Actual information. I will
flip it. So no, what I mean is all the students who did telerotation with me, all of them get multiple interviews, multiple interviews. So it worked. So I don't think so it was any different. So you are the example of that. But yeah, uh, I think telemedicine and telerotations is here to stay because first of all, the virus is not going anywhere anytime soon. Now there are new variants and this and that. So I think next 3-4 years we're going to struggle with it. So this telerotation will stay, and even if even if it opens up some of the students, it's very financially beneficial for them by not coming to US and doing it from wherever they are, because if you come here, your cost is almost double. You come here, you find a place to live, then you have to eat and this and that. And if we can provide that, at your home, so it's financially very, very viable. So we are not planning to omit it anytime soon. So because it worked very well, people who did telerotations, they got perfect, beautiful interviews. I have not seen any of my students who worked with me who had no interviews. Everybody got some interviews. Some get more, some get less, depending on the score. I'm honest with it. It's not that I was able to get somebody with very low score, a lot of interviews. No, but depending on the scores, all our students, they get enough interviews. I think most of them will match. Yeah, and I wish them luck that all of them should match actually. Yeah.
Thank you, doctor. So for those, for example, if the burden of the virus will lessen, so it is maybe reasonable to combine in-person lectures with telerotations in order to reduce the overall cost of the process, because telerotations value is also great, right?
Yeah, it's similar. It's similar.
Okay, doctor, thank you very much for this talk. It was very informative. I cannot overestimate how important it is for us because our previous interview, it was so helpful, and I believe this interview will be helpful for those who are participating in the match. Thank you for spending time with us. It is very important. I know how busy you are, but you still found the time to help IMGs from all over. Thank you, doctor.
Sure. Thank you, Julia, for you too. You spend a lot of time on this, and it's real hard work, and I really appreciate it. So other students should also.
Thank you, doctor. Bye.
Okay, Julia.